Okay, so let's dive into Module 3, the menopause consultation. I really want you to kind of understand what that looks like, whether you see us, whether you see another practitioner, whether you've been given this course through another practitioner, just to understand everything about your medical history, preparing for your appointment, your labs, and future appointments as well. So you have your medical history and what's important. So your personal medical history is really going to stand out. Your provider is going to want to know like your surgical history, your OBGYN history, any medications that you're taking, as well as your social history. As we know, medications can really impact the overall body, so that's important. In terms of family history, that's also really important, but I want you to understand and take away that this is never a reason to deny you medical treatment or therapy. So if you have a family history of breast cancer, or if you are BRCA1 or BRCA2 positive, it does not mean that you cannot use hormone care and hormone therapy, and it does not mean that you don't deserve a full discussion discussing risk, benefits, and all your question answers. We really are going to use this as a guide to kind of help us determine your risks. So that's why it's really important that you understand your risk factors, your family history, and everything to help make the best decision for you, because hormone care is very much nuanced and it's very much shared decision making. All right, so as you prepare for your appointment, you want to kind of separate the menopause visit from your annual. So if you're using an insurance-based model, just know that your healthcare provider is probably not going to be able to do this in an annual exam. It also can't be done in a quick 10-minute, 15-minute visit. It may have to take multiple visits if you're an insurance-based model. But if you are paying cash for it, usually those visits are around 45 to 75 minutes. So when you go in armed for that visit, I think it's really important that you track and document your symptoms. There's lots of different symptom trackers and journals that exist out there. We're going to talk a little bit more about that. You want to prioritize your goals. So you may have several symptoms that are happening during this transition, and that's okay, but you may not be able to get all of those symptoms discussed on that first visit, even if it is a long 1-hour visit. The goal often is that I tell my patients that within 6 to 12 months, everybody is different. You should feel 80% improvement in your symptoms from where we started if hormones are the underlying factor. So you're going to want to prioritize them. Is sleep more of an issue? I often say sleep wins that equation often because it impacts so many things. But is it hot flashes, your night sweats? Really prioritize what are your most bothersome. And you also really, really want to know your medical history and all your meds. If you tend to take a bunch of meds, bring them with you to that visit so that you can show your provider that your meds that you're on. Okay, so we talked about journaling and symptom tracking, and I just wanted to point out a couple different things that are out there. There's the menopause rating scale. We use it a bunch in our practice. It's a list of 11 different questions, with 0 being no symptoms and 4 being the most severe. There's also the Balance app that's put out by Dr. Louise Newsom and her colleagues, and it's wonderful. It's a free source. It's through Apple, and I think you can download it also in a Google phone, but that allows some symptom tracking. There's the Let's Talk Menopause symptom tracker, and there's a bunch of other trackers that are out there as well. Flow, that does period tracking, also does perimenopause and menopause tracking as well too. It's also really important for you to understand that this is actually a clinic diagnosis. We're going to use your symptoms and your menstrual history in order to diagnose it, but labs can really be helpful, but they shouldn't be relied on heavily, and we're going to talk a lot about it, especially for patients that may have premature ovarian insufficiency or in perimenopause, because that makes things a little bit more complicated. Okay, so here's where things get a little bit more tricky. Let's talk about labs by stage and kind of what's normal. During perimenopause, everything is normal and nothing's normal. It's often what we hear. And usually I say labs are not going to be the most obvious during this time frame. And I don't always use labs in my practice to navigate things. I'll get labs a lot of times, make sure there's things for absorption and things of that nature. But I think also you have to navigate on symptoms. So perimenopause makes it really difficult to get labs because your hormones are fluctuating all the time. In menopause, estrogen can often be really, really low, as we know, but it also fluctuates. So it's going to be typically in that 20 to 40 range, but progesterone is also low and testosterone can be variable. Also, FSH and LH are high, usually greater than 30 for FSH. So That's what's going on in the menopause transition. But using labs in in the menopause makes it a little bit easier to kind of navigate and see what's going on in comparison to the perimenopause transition. And then we have postmenopause. Estrogen and progesterone are definitely low. Testosterone can be low or within a normal lab range. And then your FSH and your LH are in particular going to also be high during this time frame. I think it's also important that I put on here is that you cannot check hormone levels while you're on hormonal contraception. That's often people forget that. And so you can, if you're on an IUD, if an IUD is in place, not a problem. But if you are using hormonal contraception like a patch or a birth control pill, you can't check hormone levels because they're not going to be accurate during that time frame. Okay, so there are so many different labs that are out there. There's blood, there's saliva, there's urine, there's all these different kind of tests. But I'm going to tell you that I usually go with blood. It's going to be the gold standard. It's really great for monitoring therapy and absorption of the hormone levels. When we look at saliva, it's mostly going to be inaccurate and really unreliable. And then the Dutch testing often is a lot of too much information. The saliva and the Dutch are often used by people that may not be true healthcare providers. So thinking maybe they're health coaches or other things. So you really want to try to use blood and see someone who is an advanced practice provider, a nurse practitioner, a physician assistant, a midwife, or somebody like a physician or MD or DO, because we're often going to be the ones that are going to use blood testing. And that's where the Dutch gets a little bit more complicated. There are healthcare providers that are licensed that use the Dutch, but it's a really expensive test, and I don't feel like it tells us a whole lot more than what we can get by blood. And oftentimes blood's great because you can use insurance for that. Okay, so labs are not going to be necessary to diagnose menopause, except for if you have premature ovarian insufficiency. And that means that you are either went into menopause early or you were born with hormonal issues. And so that really is going to help us diagnose that. But I think blood can be really important, but you're entitled to get lab testing. You're going to read a lot of things that say not to do lab testing, but I always say that it's an important piece to add. The Menopause Society actually recommends against routine testing, and there's no current established preferred guidelines, and that's okay. Everyone to each their own, but I like to give patients that option when they want it, because sometimes I get really valuable information, but again, I'm going to base it on symptomatology most often, especially in perimenopause where things are more tricky. All right, so you want to go to get your hormone test. What do you need to know? Usually the most important things when you're getting your hormones tested is going to be looking at your estradiol, progesterone, testosterone. With the testosterone, you want to look at the free and total, and you also want to look at sex hormone binding globulin. FSH and LH can be really helpful for the perimenopausal patient, and DHEA, it's hit or miss. Sometimes I get it, sometimes I don't. The best time to test for these patients in menopause, you can test them anytime. But in perimenopause, it gets a little bit trickier. Ideally, if they're on hormone birth controls, you're going to have them use a barrier method at least for a month. And I often will test again at the 2 to 3 month marker. And then for perimenopause, if they're in that and they're not on hormones, anywhere between cycle day 21 to 22. Sometimes I'll get it on cycle day 3. Sometimes I'll get serial labs to know what's going on with my patient. So what's normal? I think what you're going to find in this lecture series is I talk about normal versus optimal. So hormone levels, as you know, fluctuate a lot through your cycle. Estrogen can range anywhere from 50 to 500 during the menstrual cycle, and in menopause, it's usually around 0 to 20, so almost non-existent. FSH, which is your follicle stimulating hormone, it is a hormone produced in the pituitary gland. It signals down to our ovaries that it's time to release estrogen, it's time to ovulate, all those different parts and pieces. But in perimenopause, it's usually going to be less than that 35, but in perimenopause, less than 35, and in menopause, usually greater than 30 to 40. You can't rely on one set of labs in peri. That's also really important. So usually, like I said, sometimes I'll get a series of labs, but mostly in peri, I'm going to treat on symptoms, and oftentimes we're going to talk about hormones more in nature, but usually it's progesterone is the first hormone that declines. Testosterone normal is basically going to be somewhere in that 0 to 60 range, and progesterone ovulation levels are around 10. Over the next few slides, I'm just going to kind of show you some different things going on in the body during hormones and during your cycle. So as you can see, there's different things that are going on in your hormonal cycle. You have the follicular phase, your ovulatory phase, and your luteal. Follicular phase usually is the first part of your cycle. It's going to be cycle days 1 until somewhere around cycle day 13, 14 on a 28-day cycle, for example. Cycle day 1 is the first day you bleed. You ovulate around mid-cycle, so let's just call it, for ease and semantics, cycle day 14. And then the luteal phase is that back end of the cycle, usually right around cycle day 15, 16, all the way to 28 until you bleed again. What you're going to see is that levels after you've had your cycle, at the end of the cycle, they'll drop off and then they start to rise again. So cycle day 1, you can see where the estrogen and the progesterone are relatively low. It starts to rise with the estrogen through that follicular phase of the cycle, getting your body ready for ovulation. Then ovulation happens. You have this LH surge. LH is another hormone that's in the anterior pituitary, signaling to our ovaries it's time to ovulate. That rise says, hey, time to ovulate. And then once that happens, estrogen starts to plummet. So you can kind of see in the blue that estrogen is rising before ovulation, peaks around ovulation, and then slowly starts to decline throughout the cycle. That decline that's starting to happen is in that luteal phase, and that's often where people feel really symptomatic. Progesterone during that luteal phase will start to rise, but as the progesterone starts to fall, if you weren't to get pregnant, that again can cause some symptoms and situations where you're not feeling as optimal. In terms of perimenopause and your hormone levels, you can kind of see what's going on here. There's up to 3 times more estrogen sometimes in these perimenopausal times. You can see it's starting to get wonky and erratic. And that's kind of sometimes where we'll see these loop cycles where you may produce 2 cycles of where you ovulate in a month and your estrogen just starts to skyrocket and gets really, really wonky. That's why I say sometimes it's not adequate to get blood during the perimenopause time, because it doesn't give us a lot of information, especially if your labs are wonky. And then you often see this low progesterone, that first hormone that starts to deplete during this perimenopause transition. There's 3 different stages of your reproduction: the reproductive stage, the menopause, and the postmenopause. And this just kind of gives you little graphs, kind of what's going on and the hormones and how everything starts to deplete. You saw this slide in one of the other chapters that we did. I think it was the chapter before this, and A Woman's Life and Hormones. And as you can see, everything is kind of leveled and higher in our reproductive years, and then it really just starts to plummet around those 30s and 40s as we start to go through those changes. I think it's also important too that beyond just hormones, you can also get some other really good labs that help for screening just midlife health and wellness. You can look at a lipid panel. You've heard me say that there's a lot of inflammation that goes on in your body as you go through this time frame. So those things start to change, more higher cholesterol and changes. You may also get a complete blood count, a comprehensive metabolic panel. Hemoglobin A1C, that's what looks at our diabetes risk. A really good thyroid level that looks at your TSH, your free T, and your free T4. Ferritin is one of those other really important labs that I tend to look for. Sometimes I see it really, really low, which can be some of those early signs of anemia, because ferritin is kind of the storage for your iron and you want to figure out what's going on. Or I see it really high, which tells us there's a lot of inflammation going on in your body. And then vitamin B and vitamin D. In terms of screening tests, really important. We're getting mammograms after 40, but just because you haven't had a mammogram doesn't mean that you can't be prescribed hormone therapy. So again, finding a clinician that'll work with you. Colonoscopy, it really just depends, 3, 5, 10 years, and we do recommend it after 45 now. Pap smear every 3 to 5 years. A bone density every 2 years after 65, but I often get it for my patients once they go into menopause. And then pending what that looks like, I often will check it about every 2 years, potentially every year, depending if there's already osteopenia. A sleep study could be really important. Once you've kind of navigated and you're started on hormone therapy and you're not feeling at that 80% reduction in symptoms at that 6 to 9 month marker, maybe it's time to get a sleep study if sleep is still really being impacted. A coronary artery channel score about every 3 to 5 years after age 45, maybe a stress test, body composition. If you go to a place where they also do some weight loss and body composition, that's also really, really important. And then a cheap and easy thing to do is just a hip and waist ratio where you can get some really good information. I think it's really important also to consider signs, symptoms, family history, and medical history. I've just put some other labs that you can get that can be important too during this time frame. Zinc and magnesium, if there's rheumatoid arthritis or joint and other pains that are going on, maybe getting an ANA or a rheumatoid factor. You'll also see if you have that MTHFR gene, which makes you resistant to certain types of vitamins and minerals, and making sure you're getting those things in your body, or are you not absorbing them. A CRP looks at whether it's called a C-reactive protein. It looks at cardiovascularly inflammatory factors, insulin, thyroid antibodies, clotting factors, and even a genetic screen if you have a BRCA mutation in your family. I think those are really important to consider. When we think about menopause, it's beyond the labs. You heard me say a lot about symptomatology. So fatigue, it could be your thyroid, your vitamins. Again, it's important maybe to look at a sleep study if hormones aren't helping, autoimmune levels, blood sugar, and insulin. Weight gain, what's causing that? Is it you're having some issues with your insulin or your glucose, thyroid? Sleep study could help. If you're not sleeping, oftentimes there is weight gain that goes hand in hand. Joint pain, is there some autoimmune things that are going on, ANA changes? And then vasomotor symptoms, is it because maybe your blood sugars are off, prediabetes, and other things to consider as well too. In terms of more lab symptoms to consider, restless legs, hair thinning, and nighttime waking. There's other reasons to do labs if these are some of your symptoms and they're not getting better on different kind of forms of hormone therapy or working with your clinician. So you can see these different labs listed below. All right, so you've got that question, labs are normal, so you look great, no issues, no problems. But the question is are they optimal? When we look at lab ranges, they're based on a set of rules on a presence of disease or not presence of disease. And many of the individuals who go to their healthcare providers are told everything looks okay. So if your labs are a normal range, it means that you may not be showing evidence of certain diseases, but we're often taught this way in traditional medicine. And so I think it's really important to consider it. I think you look at it as a range, and some of us that embed some functional medicine into our practices more look at more optimal ranges and where patients feel their best. So that's why it's really important as you navigate this, and we'll talk about it, what that should look like. I'm not going to go a ton into lab values, but I'm going to give you a little bit of some precursors on what some things should look like. So where should my levels be to feel optimal in midlife? So let's look at some micronutrients. Your vitamin D should be between 60 and 100. You want a B12 over 800. A ferritin between 75 and 100. Lower, again, is often showing some signs of early anemia, and higher is inflammation. So when you're thinking inflammation, it could be cardiovascular, cholesterol. It also could be alcohol intake as well. That really can affect higher ferritin levels. Insulin should be less than 7. We want a fasting glucose less than 90. And a hemoglobin A1C, which looks at diabetes risk factors, should be 5.3 or less. When we look at our thyroid, TSH optimal at baseline should be 2.5. And if you're treating with medication, it should be between that 0.5 to 2. When we look at TSH for my practice, I usually will get 2 levels of TSH at 2.5, and if it's at greater than that 2.5 on 2 separate occasions, I'll often treat off-label. T3, that optimal level is going to be between 3.5 and 4.5, and T4 between 1.0 and 1.5. Ideally, you want your antibodies to be less than 0 with your thyroid antibodies, and if they're not less than 0, it often means some signs of Hashimoto's thyroid. So most providers are not going to treat thyroid unless it's well outside the normal reference range. So again, this is kind of more of a functional approach, and I think it's really important to have these discussions with your healthcare provider if you're not getting to a place of optimal once you start tweaking with hormones. All right, so up next, we're going to talk about some lifestyle pearls to use during midlife and menopause. So I'll see you in the next chapter.